Good afternoon, everyone. Once again, my name is Ferit Akova. I'm working at Geisinger Health Systems in Pennsylvania, and I joined the team a couple of months ago. Actually, the team was founded a couple of months ago. It turns out that some decision has been made to leverage the medical data that has been accumulated over the long years as medical records, other information that has been acquired and stored. So the division of applied research and clinical informatics was launched very recently, and we are the data science department under that division, working with a neurosurgeon, 2 applied mathematicians, PhD level mathematicians, myself as a computer scientist, and 2 data architects and high performance computing guys. So we are trying to establish a framework or an active research group to provide data-driven solutions in medical informatics field, which is apparently lacking compared to other fields in industry. And we are trying to bring expertise from other fields to again make similar contributions to the research or to problems to be solved in medical field. Now, how actually I was connected with Stefan and BayesiaLab was that my colleagues, Dr. Marco, who is the neurosurgeon, and the high-performance computing person, David Sanchez, was already, they attended one of the BayesiaLab classes, BayesiaLab courses, I think 2 years ago, and they, as I was coming from Bayesian learning background, they wanted me to, get myself more familiar with this software instead of, reinventing the wheel from scratch by writing my own code in MATLAB or other languages, and it really saved me a lot of time, and it probably much more reliable way I was able to accomplish what I have been trying to do with this project. So and I first and foremost thank Stefan and Dr. Juf for their help with like online meetings and other with their availability to answer questions and help me out to get over the learning curve of the BayesiaLab software and all the functionalities. So now I will try to present. Well, first let me talk about what we are trying to do with this new group. Basically, in our medical center, habitat, we are trying to do optimal allocation of limited resources under multiple constraints, such as optimizing the usage of operating rooms for making it more cost effective and more to decrease the time that it was not occupied. From that one to optimizing staff, like assigning groups of anesthesians, for instance, to certain operations that they are more productive at, and try to increase the overall efficiency or effectiveness in these kind of situations. And we are trying to do analysis of variability and uncertainty in practical data sets for basically using any data set that's available at our disposal, such as electronic medical records, other handheld devices that we are deploying on for staff to use during their daily operations, and that we can get real-time feedback from how they operate. We are trying to merge these incoming data sources into the play, and we are trying to do prediction of rare events, such as we are trying to detect if a lab that is ordered for a patient will be informative or will be just non-informative as like the 10 previous ones as it was the case. For instance, doctors tend to order labs as like a habit, but then most of the time they don't even have to look at the results. Most of the time the result is not any different from the previous cases. Then we try to do some patient-centric data analysis for this one using the available records, and we try to turn it into a rare event analysis to eliminate those redundant lab tests and decrease the cost of the operation. And these kind of things, mostly right now, initially to prove our group's utility and value, we are trying to optimize, we are trying to contribute to the optimization of hospital resources and procedures. And aside from that, I was given this project by our neurosurgeon, Dr. Marco, on a sketch showing us the protocol that lumbar spine patients, those people having lumbar spine back pain, and those who need to go through surgery or who by going through conservative management can be healed. So apparently there is a new protocol trying to be applied in Geisinger in order to eliminate those cases where even if they go through surgery, due to some other factors, it will not be as effective as it would be if had they went through those steps, which I will explain in detail, and first clinically optimize their condition, such as if they are overweight and which apparently is a major source of back pain, and if they don't tend to lose weight, then apparently even if they have surgery, it will still be a risk after the surgery. So they refer them to some nutrition consultancy to lose weight in a certain limited time, or they look at their hemoglobin. They apply the hemoglobin test to make connection with their diabetes level, and then they, if it's above a certain level, they refer the patient to endocrinology to first take care of that condition, and they try to focus a more homogeneous population as possible to increase the effectiveness of the surgical pathway. So here, what I had initially as a description of the problem is, first the patient we check whether the patient has gone through conservative management, meaning that either physical therapy or injection therapy or medications, oral therapy, as they say. If that's the case, and if it turns out to be a success, then that patient simply goes home. Otherwise, if it's a case for surgery, then there are some pre-surgical screenings, such as look at the MR image, or as I said, take the hemoglobin test for the diabetes, or the nutrition consultancy, or smoking cessation if the patient is a smoker. Those kind of things help the process to be more, as I said, effective and focused on the condition that the patient has been suffering from. So if they pass all those 5 pre-screening steps, then they are referred to the surgery, where there is a bunch of default tests and small courses that the patient has to take, and then they are taken to the surgery. After the surgery, they, depending on the condition, or depending on the severity condition, or depending on the result of the surgery, they go through different pain management strategies. And all these, not all, but some of these steps incur cost, obviously. So the one goal is to predict the outcome of the surgery by looking at the background variables, such as the demographics, such as the patient's weight, height, age, other risk factors, and then the other goal is estimating the cost of a patient of a population of patients had they go through this protocol, and in the end, what would be the cost of treatment for this group of patients. And the other goal of this project is, if we know the outcome, if we want to look into the patients who would go home or who would go to a rehabilitation center after the surgery, what would be their characteristics in terms of the demographics, or in terms of, as I said, like age, sex, BMI, other related things, so that we can go out to the customers and offer them a predictive answer, or a predictive process that they can give us information about their population, and we can tell them that with that probability your patients would cost that much dollars as a result of the treatment. And this kind of objectives lie behind this project. So apparently we developed a Bayesian network for this job, and as you all know, there are other alternatives, such as using decision networks to try to model the diagram, as I tried to explain a while ago. But we know that answering questions in a probabilistic way gives us the flexibility to do more than what we can answer, what we can answer by just looking at the data. We can incorporate the prior knowledge. We can incorporate the expert knowledge as we work with doctors. Other than that, we can naturally do feature selection, or which we can decrease the complexity of the problem by representing the same joint probability distribution with in a more compact way, as we all know by the beauty of Bayesian networks and the conditional independencies. Other than that, we have the ability to play the network backwards, as I was telling. By looking at a certain outcome, when we introduce the evidence of the target node, we can look at how the distribution of the independent variables change, how they are affected, and then we can do decision making according to that change, as I will try to show some results on that. So the current Bayesian network that we have been working on looks like this. So there are three parts. The upper right is the conservative management part that we are trying to model it in as detailed as possible by consulting to the doctors. Then we have the upper left part that corresponds to those pre-screening tests before as the patient has to go through before the surgery, and the bottom part is modeling the surgical outcome using the available features, which is a simplistic model, by the way, as I will also explain how to make it more advanced, which is actually the ongoing work that I will be doing. This is effectively 2 months of work, and before that we had to deal with data acquisition, data cleaning, and all that stuff, which is apparently a major problem in medical data. So, so let me start with the conservative management part. Here we focused on three types of therapies: oral therapy using these kind of medications, and then physical therapy and injection therapy. The patient, someone with back problems, can go through either of these or more than one of these at the same time. And depending on the data that we have collected over the years, we try to estimate the prior probabilities of patients going through conservative management through each of these branches. And then, as a result, the status of the conservative management can be either the patient has just recovered and went home, or surgery has to be conducted on those cases. So I will show you some numbers to give you an idea about what kind of cases we deal with. So roughly we had 4,100 patients in the system that we were able to access their records, and all these numbers show on the edges, on the arcs, actually show that, for instance, about like 22,000 patients had taken the medication related to nerve pain. Like 11,000 patients has gone through injection therapy, and or 70,000 patients has gone through physical therapy. And in the end, this arc shows us that only 3,000 of those patients has gone through surgery, and the remaining we don't know what happened to them. They might have gone home, or other treatment options might be required, or they might be transferred to some other facility. They might have moved from the area. We might have lost connection with those. But for this project, the focus is on those patients who has gone through surgery. So apparently we have around 3,000 patients, and that's relatively limited if you want to use above a certain number of features to model that phenomena. So we were trying to be careful about selecting which features to use, but apparently not by using the techniques that I learned in the causal inference course, or other features that Bayesian networks would help. We were trying to do it by hand, or by asking to the physician. But apparently, I will have some take-home messages at the end by attending this 1-week program here. So now the second part, actually in detail, as I said, there are 5 things that the patient has go through. First one is taking their image, MR image, which is a default thing. So we don't have to, there is nothing to model about this. It's not like a decision that's either there or not. So it's always there. So body mass index, the BMI of the patient, has to be below 40. Otherwise, they are not allowed to, go through the surgery. They are referred to a clinical nutrition consultant. And then if they are a smoker, they are asked to cease smoking for at least for some time, so they are referred to the smoking cessation programs. And when they take the hemoglobin test, its value has to be below a threshold, otherwise they are referred to an endocrinologist specialist to do the necessary thing to take care of that condition. And osteoporosis is generally a risk for ladies more than gentlemen. So also either a DEXA scan, bone density scan has been conducted, or some other methodologies can be used for that. And once we have these information ready, we use it as a cutoff. Currently, how we modeled it as a cutoff point. If the patient satisfies all those 5 conditions, then they are referred to the surgery. Otherwise, it's like a 6-month re-evaluation period. Then again, looking at those values, we make the decision whether the patient or the set of patients, population of patients, can be suitable for surgery. So right now, this is how we modeled it. But of course, another way to look into it is in a probabilistic way, with a more careful analysis of each of these nodes. Some of them might be more important, such as the BMI obviously might be more important than smoking, which just out of my intuition. So when we model this part in a probabilistic way, then it will also affect the surgical outcome, because then we can play with the values of these thresholds and see how effective that test on the surgical outcome. Then we can even remove some of those steps if they turn out to be useless or non-informative. So these are the following steps that we will be looking into as we now approach today's level that with a working Bayesian network model. So this was the initial model that we tried to come up with, but due to limitations of obtaining certain fields, certain variables in data, we limited it into a more simplified version. But now, other than data limitations, there is also technical limitations, such as we want to incorporate comorbidities, other diagnoses that the patient is currently being treated, or other medications that they are currently on. So in this case, there is some design decisions that has to be made. For instance, there are 900 medications that can be prescribed by doctors, around 900. So if you want to model this as a vector of 900 values, binary variables, then the inference would turn out to be a really difficult case because of the lack of enough data. Otherwise, if we try to limit ourselves to the first 10 most frequently used medications, then it will obviously make it easier for the inference, but then we will lose some specific information, some discriminative information for certain cases. So I believe I will be ping-ponging with Lionel or Stefan about how to tackle these issues, or maybe it might even open up some discussions or collaborations for maybe improving the inference of our project. So having talked about this, now this is a sample data set that we usually obtain from our data architect. He goes into details of the database, and actually he is the only one who is authorized to extract data from database because of the anonymity issues. You have to get the data de-identified. There is HIPAA restrictions that it needs to be abide very carefully. So what we get is a de-identified data set with some patient ID or with some patient encounter ID when they get into the hospital system. Then we have the demographics. We have other admission-related features such as the admission date. Then which hospital facility is it in which city of Pennsylvania were they treated, or which facility were they taken care of. Other than that, admission, post-admission variables such as the initial examination of the physician by assigning an initial diagnosis code, and then discharge-related variables such as some discharge DRG codes, which is I think discharge groups. yeah, I forgot what it stands for, but there are two different DRG codes that sort of identifies what is the condition that the patient has been seen for and discharged. So we try to make use of these variables to model the surgical outcome prediction part, which is the below part consisting of blue nodes. So what I have done actually to come up with this network is I used the available data for the conservative management part, because we had enough data, which is also sort of not directly connected to the red section of the graph, but obviously which might be very useful to be connected with the surgical outcome. If a patient has already gone through conservative management, which of those which of those branches he has gone through might have effect, might give us an observational answer on the surgical outcome, or we might even go in more detail by looking into a smaller subset of those variables connected and try to look into a causal effect, which might be the most important set of features on the outcome. So these are the questions that we will be asking from that point on. So for the upper left part, we didn't have enough samples for estimating the prior probability. So what we did was we tried to query 10,000 random patients from database. We tried to match the statistical descriptive variables with the ones that we have for the 3,000 patients we know who had gone through surgery. So we tried to mimic their case with those randomized population and try to estimate the prior probabilities of patients passing or failing through those nodes. And then for the surgical outcome part, obviously we needed to use whatever we have available, roughly about 3,000 records, some of which are noisy, some of which are well, I forgot to show you some funny values in the BMI. There were some patients with BMI over 3,000, so or height with 18 inches of tall at the age of 18. So these kind of things, unfortunately, are the ones we need to deal with manually by either going through some analysis scripts to eliminate those erroneous records, or as Stefan helped me out to figure out that to consider them as filtered values, and then you don't lose you don't lose the whole record, but only those problematic fields are excluded from the model learning. So these kind of things helped us to use as much of the data as we have, and we came up with this predictive model. So here's just a example of the result that we can obtain. Now the target variable is basically after the surgery, the patient either goes home, which is label 1, or actually probably I just changed the slides. Initially our states of the outcome was for 3 different cases. First one is going home, second one is going to rehabilitation center within the hospital or at some other facilities, and third one is going to a skilled nurse facility, which is usually specialized for older people. And 0 is other, stands for the other cases such as surgeries resulting with death, or people who are just leaving the objecting to the treatment and just leaving and somehow deciding not to go through surgery or medical advice. So we try to model this into a 4-state problem, and here it's a 80-20 distribution of the samples as training and test set respectively. So it turns out that class 1, the ones who goes home, can be predicted at a reasonably high accuracy, whereas the second class, which is a combination of the rehabilitation center and the skilled nurse facility here, is not as good as the first case. Well, here first of all there is this bias of the prior probability of patients going home. There's an imbalance of on the decomposition of the patients in the data that we have, and other than that, those two groups going to rehabilitation center and skilled nurse facility have a lot in common in terms of their conditions. So we need to find out more discriminative features in order to be able to do a more fine-tuned analysis on that class of patients. So, but initially these results were enough to make us happy to show that it's working. There's potential utility. And we can show the medical audience, we can show the doctors that we can use the data. Actually, they feel happy when they really see that what they know is what they already know is confirmed with the data that's there. So we never claim that we are replacing their opinions. We are just trying to provide a second reader so that it's good to have this communication and help both ways. So we were able to obtain this result, and obviously when you increase the training data size and decrease the test data size, this results gets slightly better, and this is around 150 patients of a test set that we reserved for final validation gave us a little bit more better results for both classes. So other than that, we, as I said, try to look backwards. So we wanted to see what would happen to the distribution of, for instance, those simple features that can be obtained for pretty much every patient coming to the hospital. We looked at the ones labeled with going home, and I don't know if they are visible, but the directions of the arrows and the differences between the bars show us that some features have are affected more, some are relatively indifferent to the change. But what it verified is basically age is definitely an important factor in discriminating patients who went home or who went to the rehabilitation center or the SNF. And similar analysis have been done to talk to, as I said, the doctors in doing brainstorming for what can be done with these kind of models. And we also looked at other features. We included more detail about the post-admission features, which were more helpful in determining the outcome. So again, we have verified our initial expectations about, such as the severity level assigned by the initial physician turns out to be an effective one based on the outcome when we change it from home to the other rehabilitation center, for instance. So this kind of analysis is good to see visually what the data is telling us, what the data speaks for itself. And for the prediction, now here comes the feature selection part. For the prediction, these are the features that we used: patient's age, sex, weight, height, etc., and other admission-related features, how many days they have stayed in the hospital, what is the severity level, these kind of things. But some of these features have a lot of states. That's difficult to, when you look at the conditional probability tables, it's going to be huge, and then you want to avoid these situations either by aggregating values into a smaller number of bins, or including more samples to be able to accommodate that many states in some of those features. So now the idea of looking into causal effect between features is going to help us a lot to determine if among two features they are pretty much affecting in the same way, but one of them is more costly. So we will drop that feature and we will do more in-depth analysis in terms of feature reduction. And this was the example that I showed to the doctor fellow about effectiveness of features. Apparently, I wasn't sure if I was using this figure in the correct context, but I was showing that, okay, it looks like the direct effect also of those features on the outcome are this and this and this. Some of them made sense, some of them were surprising, some of them hinted us that it might be an observational case. For instance, the hospital location turns out to be relatively effective than others. So probably it's an observational situation, like whatever patient population lives around that facility might have problems. So
what kind of state do you have here?
This is the outcome variable.
No, with the hospital location.
We have 5 or 6 different.
But it's a geographical.
Well, yeah, within the state of Pennsylvania, different. Yeah.
Because here, in order to
Yeah, it's discrete.
Without any order, that does not make sense.
Yeah, I remember that discussion you made with Felix. So yeah, probably, as I said, I wasn't sure if this, what exactly this tells us, but now I know, I have to use it in the more, context, correct context. So now again, there are other functionalities that we didn't have time to analyze whether might be more reasonable for us to, use to talk about the data, talk about the findings. Now, the next thing we will be doing is modeling the cost of the treatment protocol. Obviously, some of the nodes will have cost values incurred, and some of the nodes do not have any cost-related states. So we have a also Geisinger has its own health plan. So we are in contact with those financial department to obtain the real costs of the procedures, such as different CPT codes representing different surgeries, or those conservative management therapies, depending on which one the patient has gone through. Obviously, the cost will be different. So it will help us use the cost analysis and make a more effective planning in terms of offering the line of service to the patients for specific diseases. So this will be the other thing. And also another question that might be asked is it more, what happens when we correctly identify those patients who would go home compared to if we correctly identify, or let's take the opposite way. What happens if we misclassify those patients who would go home as who goes to rehabilitation center? Obviously, the cost of these misclassifications are different. So it will help us to accommodate resources in a better way if we can come up with a better prediction way. So these kind of questions can also be easily answered using the Bayesian network framework if we, as Julia probably yesterday suggested, work hard on the construction of the network and then using the mechanistic steps to make use of it. Now again, as I said, this will turn out to be useful for resource allocation and cost effectiveness in terms of the internal workings of the system. So of course, there has been limitations. First of all, to deal with medical data, it's never clean. Not only missing data, but as I said, a lot of erroneous entries in the system. So it requires some pre-processing effort before you can use it in a more reliable way. Other than that, again, we have a limited number of spine surgery patients that we try to use as best as we can. But as I said, in some cases, it was possible to get around this by using a random population to match the statistical descriptive statistics with that group. And other than that, we have difficulty in obtaining some of the features in a formatted way. Some of them are simply free text form, which requires natural language processing techniques to be used to extract useful information. So these are all the things that will be somehow handled in the time. So the continuing work on this is basically, I haven't implemented cost model yet, so I'll try to incorporate a comprehensive cost model to run the network, play the network forward, and in the end come up with an expected value of cost for, as I said, a specific patient or a subgroup of patients. Other than that, we will try to do include more features, more variables to come up with a better predictive algorithm. So possibilities are about patients' family history, whether they do exercise, what occupation are they working on, or as I said, like comorbidities, current medications, blood values, which would be vector valued features. As I said, it's another story to tackle this technically, and other risk factors that's difficult to obtain for each patient, but if it's there, we can take advantage of them, even if it's only available for a small number of patients. So these kind of things will be the technical things that we'll be busy with. And other than that, as I mentioned at some point, it might be possible to identify if any of those pre-surgery tests are redundant or irrelevant or non-informative. So we will try to make a probabilistic model to answer that question. And finally, as also some of the other speakers mentioned, it might be very important to choose to play with the discretization method of continuous variables more carefully. So these can be considered as a fine-tuning of the available network to get better models. And again, missing value imputation or using the records, using only the cleanest records might be a better asset, but then it decreases the number of samples available to you. And also the comparison of structured learning alternatives as also is answer to a similar question. I'm usually defining the target variable and then using the structured learning algorithm to come up with an initial model. And usually I go with the default model that it gives me if I use the naive Bayes, augmented naive Bayes algorithm, because I don't have many features to limit it into the Markov blanket or something. I try to make use of the available features as much as possible. So these kind of decisions are obviously very important, which means I'll be in contact with Lionel and Stefan more to figure out what might be a better way to model that part of the Bayesian network. And I guess, yeah, as I said, I got some take-home lessons by attending the classes here and listening to the talks. First of all, we haven't incorporated much expert knowledge into this framework because we try to work on a more data-centric fashion. We try to make use of the data and we try to come up with the prior probabilities and then use the future data to, basically effectively model the posterior probability and come up with the probabilistic answers. And then as I said, we are able to use causal effects to identify those features that might be more reasonable and beneficial to focus on. And apparently, Felix's course was a invaluable chance for me to attend and learn a lot and keep looking into it. And then, as I said, I thank Stefan and Lionel for the tips and walkthroughs for me to recovering the learning curve. And as he said, I didn't have a chance to attend any of the classes, but I had the chance to read the notes of Dr. Marco from the 2 years previous course, so which is still something that I was able to learn a lot about the BayesiaLab. So this is pretty much what I have to say. So thank you so much for listening.